Clinical management of multivalvular heart disease requires a precise navigation of conflicting hemodynamic signals. Inside a functioning cardiovascular system, blood moves under high pressure, channeled by valves opening and closing with synchronization to maintain a constant forward surge. When multiple valves fail simultaneously, such as the aortic and mitral valves together, the heart enters a state of compensation, where one failure actively masks the severity of another. This chart highlights a clinical trap. In combined disease, left ventricular ejection fraction may appear higher than actual myocardial function. The struggling muscle appears healthy on scans. This discrepancy creates high surgical risk for double valve procedures, carrying a 10% operative mortality rate. Because these overlapping pressures hide the true state of the muscle, clinicians must look past resting scans to find the underlying failure. This is often managed through the 2 moderate rule. It dictates that when a patient has 2 moderate lesions, such as stenosis and regurgitation in the same valve, their combined clinical impact can equal that of a single severe lesion. Standard metrics often fail in these mixed scenarios. Pressure half-time becomes unreliable for measuring mitral valve area because shifting pressures influence the reading. To find the true symptomatic impact, an exercise stress test is required. By putting the heart under load, clinicians bypass the illusions of a resting scan and see how the valves actually perform during physical activity. Treating mixed disease requires moving beyond passive diagnostics and actively challenging the cardiovascular system's limits. In the left heart, failure begins with aortic stenosis. As the valve hardens and restricts flow, pressure inside the ventricle chamber violently skyrockets. This intense back pressure eventually forces the neighboring mitral valve to leak backward, a condition known as functional mitral regurgitation. This secondary leak creates a diagnostic interference, as the backward flow can artificially elevate the pressure gradients measured across the aortic valve. To avoid misleading gradients, use the AVA continuity equation shown in this orange panel. The surgical priority is strict: correct the aortic stenosis first. Once this blockage is cleared, functional mitral regurgitation improves on its own in 60 to 70% of cases. In cases where the aortic valve is both stenotic and leaking, intervention is required once the peak velocity reaches 4.0 meters per second. Tracking this chain reaction allows the team to distinguish primary failure from secondary symptoms. A different conflict occurs when mitral stenosis is combined with aortic regurgitation. Here, blood flow is simultaneously restricted from entering the ventricle and leaking back into it from the aorta. These colliding flows make pressure half-time measurements highly unreliable for assessing the mitral valve area. Because of these pressure dynamics, this gold panel indicates a critical rule. Percutaneous mitral commissurotomy is generally contraindicated when aortic regurgitation is present. Managing the left side of the heart also requires a comprehensive look at the right heart, specifically addressing lesions like tricuspid regurgitation. If the tricuspid valve's annulus dilates to 40 millimeters or more, a repair should be performed during other left-sided surgeries. Guidelines vary slightly. The AHA-ACC labels this a Class 1 surgical requirement, while the ESC classifies it as Class 2A. Once the structural plan is set, the team must decide on the permanent hardware for the replacement, the mechanical valves. This choice is driven largely by the patient's age and the long-term durability of the material. Looking at these preferences, the AHA suggests mechanical valves for patients under 50, while the ESC extends that recommendation to those under 60. While these valves fix the physical mechanics of the heart, they also necessitate a lifelong change in the patient's blood chemistry. Because of the risk of clotting on mechanical surfaces in these complex cases, this panel notes that novel oral anticoagulants, or NOACs, are generally contraindicated. Managing multivalvular disease depends on identifying diagnostic discrepancies, following established surgical hierarchy, and maintaining strict pharmacological control long after the patient leaves the operating room.